Okay, so we're recording, and so we'll go over antibiotics and antifungals. This might have been, I wanted to pull up the Moodle course. If you guys have a chance to look at that too, just notice that some of the chapters are kind of broken up a little bit. You got like a little bit of chapter, most of chapter 7, a little bit of chapter 7 that's going to be next week, a little bit of chapter 8, and then we also have a little bit of chapter 1 with the prescription writing. So it's a little bit kind of all over the place with the readings for this week. And that's just how, when I inherited the course, that's how the original instructor had kind of set it up. So I haven't changed it as of yet. So these are the objectives: describe the mechanism of action and common uses for the discussed antibiotics. So those are the main two objectives. Is kind of what are they commonly used for, noting especially if they're used for something dentally related. If it's like a UTI or chronic bronchitis or something like that, those are good to know or nice to know, but it's really important to kind of hone in on things that either affect something orally or like when your patient is in the clinic, or if they're being prescribed for something dentally. So any kind of really specifically dentally or oriented, whatever the word I'm going to say, then that's when you really want to make sure you're paying attention. List pertinent drug interactions, adverse effects, and contraindications for the discussed antibiotics. Some of them have very specific adverse effects, like there might be a very specific adverse reaction to alcohol, or there might be a very specific drug interaction with warfarin, or something like that. So there's going to be a few of those. Fortunately, they sort of are a little bit repetitive. Like warfarin keeps coming up with many antibiotics. So that's kind of helpful. So note those repetitive things, those things that kind of show up over and over again. And then as far as adverse effects, you're going to note that it's really common to have GI issues or allergies. Those are just very common things with antibiotics: GI issues, allergies. So it's not as like overwhelming as it might sort of appear in this presentation, because there's just so many medications. There's so many different antibiotics. So all of these in red, these are obviously not all top 20. I can't exactly remember which antibiotic is on your top 20 specifically, but these are just very common. So they're kind of all lumped into that kind of need to know, because you're going to see these a lot in private practice. So, and you've probably taken, I'm sure a percentage of you have probably taken one or more of these at least once or multiple times in your life. This slide here is kind of demonstrating the chain of infection. So it kind of shows all the things, and we've been talking about this kind of material for so many, 2 years now with COVID and everything. So we talk about all of this stuff like susceptible hosts, portal of entry. How is the bacteria or the aerosol with the virus or whatever it is, how is it getting into our bodies? How can we spread it? How does it exit? Is it blood? Is it some kind of other fecal matter or something, or is it an aerosol? Are you coughing and sneezing? So all of these things. So this just sort of shows sort of the chain of infection, but how it can be broken. So how you can prevent transmission, or how you can treat into a disease to stop that transmission. So this is sort of nothing that you're going to necessarily be tested on specifically, but sort of good for your understanding. Educating people about sources of different diseases, that's a big part of it. Talking about keeping our immune systems healthy, and education on that is a big part of it. The susceptible hosts are going to get sicker. So all of these different aspects are really important for us as healthcare providers to understand. Okay, so antibiotics and terminology. So there's a few things words that you're going to really want to know that you'll probably be tested on. Specifically here, bactericidal and bacteriostatic. Those are two words that are going to come up again and again. So first we have antibiotic, which is a chemical substance produced by microorganisms that can destroy or suppress the growth of an organism. So it's targeting an organism by either trying to kill it or trying to prevent it from replicating and thriving. And then that kind of blends down into these two terms, bactericidal and bacteriostatic, because this sort of explains that a little bit further, what actually happens in the different types of antibiotics. So bactericidal is the ability to kill a bacteria. So cytal, that word kind of triggers that death. It means death. It's trying to kill the bacteria. And then static, you can think like it just kind of tries to freeze it. It just tries to slow it down and make so the bacteria just can't replicate. Because we know that disease is oftentimes like an imbalance of anything. You just have too much bad stuff. And so then you are expressing these symptoms of disease. So when there's an overgrowth of a bad bacteria or a virus that's taking over, then that's when you have all these disease symptoms. So if they can freeze it, if the medications can mess up its ability to replicate, then it's going to help with the disease symptoms. So bacteriostatic is the ability to inhibit the growth of the bacteria. Then we have a couple words, resistance. You guys have all heard about that probably, I'm sure, and even in your prerequisite courses, talking about antibiotic resistance and how if we use antibiotics in the inappropriate ways, then bacteria, they mutate, bacteria and things mutate, and then they're resistant to that antibiotic. It doesn't work so good anymore. So there's that whole only take it when you need it. It needs to be prescribed appropriately, take the full course. If you just kind of take it, but you leave a few stragglers, they might develop some kind of a resistance or rear their ugly heads even stronger. So the ability of an organism to resist the effects of an anti-infective agent is resistance. In superinfection, an antibiotic disturbs the normal microbes in the body and causes another infection. So the goal is, and this is going to be repeated in further slides down the road, but the goal is to target that bacteria that's causing the disease, but a lot of times we wipe out good bacteria as well. So we can set ourselves up for superinfections, or if somebody is severely immunocompromised. So just like what I said, when are antibiotics necessary, the bacteria is sort of usually going to take balance is going to be out of whack. And so the bacteria has taken advantage of that somehow, is producing sort of a disease effect. So our own immune system is amazing and very capable, but there are times when our own immune system isn't able to fight back as effectively as we need to. And so antibiotics kind of help give our own immune system that boost by killing whatever it is that's growing out of control, and then giving our own bodies a chance to take care of the rest. So the main reasons that antibiotics will be used in dentistry are to treat, obviously, like infections in the mouth or the head area, a bit in the mouth. So, abscesses, periapical abscesses, when there's a lot of swelling and there's lymphadenopathy and there's swelling in the lymph nodes. And for sure, those are times when an antibiotic will be prescribed. Prophylaxis against infective endocarditis. So if somebody is either at high risk for IE or they've had IE in the past, then they'll get a prophylaxis with an antibiotic. And then patients that are either at risk or have a very low immune system, they're immunocompromised. They may pre-medicate them just for a cleaning if they're super immunocompromised, because they have a higher risk of having a bacteremia, which is blood in the bacteria in the blood, bacteremia. Bacteremia happens actually all the time, but we just can handle it, like healthy people can handle it. Okay, so just a little bit of background on antibiotics and how they first came around. You guys probably remember this from some previous courses that you've had in the past. I have a little bit more kind of nice to know information in the notes that you can read through that you're not going to be tested on, but there's so much material, I'm not going to spend time really going over that, but kind of some interesting, nice to know facts there. 1928 was when penicillin sort of first was discovered by some accidental Petri dish contamination, but then realizing that, oh, hey, this is actually killing some bacteria, some staph bacteria that was accumulating. So kind of by some bad lab practices, the scientists discovered penicillin. And like it says in the notes, people have been using things with natural antibiotic, antifungal, antiviral properties holistically for centuries. They might not have known specifically what was happening, but they have been around in other ways. But that was when they first really started isolating and like prescribing and marketing antibiotics and that. So the goal of antibiotics is to not kill the host. That sounds like a good goal, right? We don't want to kill the person, but we want to kill the bacteria, the bad bacteria. So I don't know, you guys will probably hear different things. Different doctors will say different things. I just remember Dr. Blizzard I used to work with and when I worked for Dr. Matsuda, and she was an associate of his back in the day. And she would always tell her patients, okay, here's your antibiotics for your surgery and make sure you eat yogurt while you're taking this. So some doctors will say that, just eat yogurt for the probiotics to basically help your gut flora and not get completely wiped out. Some people say, well, should I take a probiotic pill? But our probiotics nowadays are like 50 billion, blah, blah, blah. So then I've heard other doctors say, don't take them at the same time. I don't really know what the right answer or the wrong answer is. And I think that's a wonderful thing for you to talk with your doctor about, or reach out to somebody, a physician or an expert, a gut maybe expert, to know how to talk to your patients about that if they ask you, because it's definitely something that is one of the main side effects of taking antibiotics is wiping out good gut bacteria. And our gut bacteria is super important, so we don't want to wipe it out. So that's just a kind of an interesting thing to find out more about, whether or not they want to take it at the same time or stagger it, or just do something like eat yogurt, if that's not typically in their diet. So again, we want the antibiotics to be highly selective, but they're not always, and usually they're not highly selective, but that's the goal. And then with antiseptics, adverse or opposite to antibiotics, antiseptics kind of just wipe out everything. They just kill everything. So they're not selective in what they do. They just kind of. So chlorhexidine, that's the mouthwash that we prescribe or we give to patients when they're after surgeries, like oral surgeries, or if they can't brush and floss very good, if they're in the hospital or something like that, they might get chlorhexidine. That sort of wipes everything out. Bleach is another example. Byrex oh my gosh, the wipes that we use, Cavicide, it just kind of wipes everything out. So the goal is to discover sort of the difference between human cells and bacteria cells, and then target the thing on the bacteria that that is different from humans, so that we can kill that and isolate that and sort of be selective. So there's a few main differences that you guys just need to be aware of on a very high level, not getting into the depths of biology and microbiology and whatnot. So bacteria have cell walls and we have cell membranes. So that's a big difference. So some penicillin, for instance, targets the cell wall of the bacteria. So it's not going to do anything to our cells because it doesn't target cell membranes. So it's fine in that respect. So that's a big one. Different ribosomes. So we're just made up of different parts, even though there might be some similarities. It's different. A ribosome is different for a bacteria than it is for a human. And the same for viruses and funguses and things. And then making new DNA or RNA, they use different sort of protein synthesis systems to synthesize proteins as building blocks for their existence. So when the medication targets these different things, either the ribosomal, the ribosomes, or something that's some kind of a protein synthesis in the DNA or the cell wall, they're targeting something that isn't going to affect us because we don't have the same parts, basically. We talked about this a little bit already. Bacteriostatic, bactericidal weakens. If it's static, it basically weakens or disables the growth, prevents it from flourishing. And then if it's cidal, it kills. So we already kind of talked about that. And then this if you click on this, it's like a paper or it takes you to a website and it goes into this a little bit more. You don't have to worry about that for studying for an exam or a quiz, unless you want to kind of sort of understand the difference. There is some important key points to note, and that's that some drugs can be static in lower doses and cidal in higher doses. You also you can't prescribe a cidal and a static at the same time. They have to be taken at different times because they sort of don't work well together. They kind of counteract each other or something. So doctors will know that. You don't ever really have to know that because you're not going to necessarily prescribe antibiotics unless you have a specific kind of a contract with a dentist and you're an EPDH out in public health. Then you can actually prescribe antibiotics, but we'll talk about that more later. But anyway, so there's some interesting things to know. And then some drugs might be static, like I said, in one dose and cidal in another. I already said that. So those are interesting to note, but you don't have to know those for a quiz or an exam. So I don't want you to stress out. That's just an interesting addition if you want to read more. It's not a long read, it's like one page. So the end result of hitting the target, the cell wall, they lose their sort of protective structure, right? And then the contents of the bacteria can leak out, and that's obviously not going to be healthy for the bacteria. And then, I saw the neatest video the other day where there was all these little microbes that were in just water, like tap water, and freaky deaky. I mean, they look like little bugs and they're just in tap water. So I didn't really want to think too much about that. But then it was showing like a surfactant or like a soap. It was something that's in a testing kit. It was something, but when it hit these little microbes, they're like swimming and they look like all together and you could like see their cell walls and everything. And the minute that surfactant or that fluid hit them, they just kind of went like bloop and they like just fell apart. And their little guts just went across the little slide. It was so creepy. But I was like, oh, it gave like a good visual for kind of what happens. Like their cell wall is weakened, and then the pressure inside just sort of, and they just burst, and that's the end of them. So that's what's happening when you take something like a penicillin or a cephalosporin. It's attacking the actual cell wall of the bacteria. Then again, we have the different ribosomes, inhibits protein synthesis. They can't make new cell parts. So it's going to sort of weaken them, or that they'll be static is that word, just kind of frozen. They don't flourish. So examples of that are macrolides, tetracyclines, and clindamycin, which we'll talk more about in a minute. And then we have the DNA or the RNA. And this can also lead to death because if you mess with their genetic code, if you mess with anybody's genetic code, you can't reproduce in a healthy way, and then you're just going to die out. So, okay. So gram negative, gram positive. This is, you guys probably remember this. How did you remember if it? I always think like I positively can see purple. I don't know why, like that in my head, like, do you guys remember talking about gram negative, gram positive in your prereqs? Yeah. So there may be a question on gram negative, gram positive on a quiz or exam. So knowing that the gram positive has the thicker peptoglycan layer, and it just, but it doesn't have this outer protective membrane, so it just absorbs more of the stain. So it shows up dark purple. So I always said to myself, I'm positive I can see purple. I don't know why. That's just what I said in my head. So that's gram positive bacteria. And then negative, they don't absorb that violet stain because they have a thinner peptidoglycan and they have this protective outer membrane. So they don't show up with that dark purple. Okay, so a couple things. So when we talk a little bit more about the differences, so the cell wall has a beta-lactam component that helps build the wall. And this is true for the penicillins and the Prophylactic drugs, antibiotics. And so the beta-lactam antibiotics specifically target this beta-lactam ring that's on the bacteria. So the cell wall, the beta-lactam antibiotics, they kill the bacteria that is surrounded by a cell wall. So this is just explaining a layer down. It's still attacking the wall. That's how it's going to kill it, but it's specifically targeting this beta-lactam ring. So that's what is the kind of takeaway point here. Beta-lactams block this process of the building blocks of building the cell wall. And without that support, then the cell is going to rupture. So they're attacking this beta-lactam ring. It's going to mess up this bacteria's ability to build a protective wall. And then the wall ruptures and the bacteria dies. So this is seen in penicillins, amoxicillin. Amoxicillin plus this clavulanate is augmentin. Have you guys heard of augmentin? Has anyone ever had experience with that? That's sort of a common prescribed medication, augmentin. And then cephalexin or Keflex, that's another common one. Those are from the cephalosporin family. So all of these are beta-lactam antibiotics. Yeah. That you don't have, I'm not going to get too specific. The book is probably talks about that, but you don't have to know it to that depth because there's too many antibiotics. And then and there might be some in the PowerPoint that mentions it, but you're not going to have a lot of testing, if any, on if an antibiotic targets gram-positive or gram-negative. Because that's just kind of goes into a little bit depth that I'm not sure we really need to enter. So here is just sort of a little breakdown of things. This is the medication. So penicillin, amoxicillin, or the augmentin, which is amoxicillin, and it's called something acid, galvanic acid. But anyways, it helps strengthen the amoxicillin because amoxicillin is a little bit more prone to the enzyme that works against the beta-lactam. So I don't know that that's probably more information than you need to know, but that's why they add the galvanic acid. It's in your textbook. But anyways, that's what creates augmentin. So penicillin has a very narrow spectrum. Amoxicillin has a much broader spectrum. Like Jenny was asking about gram-positive, gram-negative. This is here, but I don't think this is going to be something that you're not going to be tested on positive and negatives. And then these are the common uses. So this is oftentimes penicillin will be prescribed for strep throat or an ear infection. Amoxicillin you'll see for various things. It could be for a tooth, something dentally related, like a tooth infection or some kind of odontogenic infection, tonsillitis, pharyngitis, a lot of stuff in and around the oral cavity. And then augmentin, UTIs, urinary tract infections. So a little bit more complicated, and you can see the spectrum is a lot more broad. Anaerobes, so oxygen, like they don't like oxygen, right? And gram-positive and negative. So this is a little heavier duty antibiotic and for more complicated or intense infections. So what are some of the issues with penicillin? So drug interactions, this you can just kind of across the board say it with most antibiotics, is that you have to make sure your patient is taking an alternative contraception other than just an oral contraceptive. If they're taking like a birth control, they need to have a backup just because it reduces the effectiveness of the oral contraceptive. So they need to rely on something else. And so that's with almost all antibiotics. Possible decreased efficacy with tetracycline drugs. So again, taking two antibiotics together, sometimes they counteract each other. Specifically, it appears to be tetracycline with penicillin. increased toxicity with a methotrexate drug, which is an immunosuppressant, and then increased effect on warfarin. So I would highlight or put a star by increased effects of warfarin because several of these antibiotics do that. So warfarin, they tend to, when we're talking about drugs being absorbed and enzymes or getting things being metabolized, if anything gets in the way, then that might lead to an increased blood level of a different drug that you're already on, especially depending on the affinity. We kind of talked about that. And so a lot of these antibiotics will kind of mess up that absorption metabolism process. And what ends up happening is warfarin ends up being in a higher concentration in the blood. And that's usually dialed in pretty specific. And so you don't really want medications messing with that. Common adverse drug reactions, rash, in a small percentage of people, nausea, diarrhea. It's less so with, I always hate, so this is greater than, wait, is it greater than? So is this saying, you guys are going to have to help me read this. So is Augmentin okay, for the nausea and the diarrhea, that must be what that is. I don't like that way of saying it. I'm going to rewrite it so I get it better. And then yeast infections. Yeast infections are a common adverse reaction. And this goes again, and you'll see this coming up too, and this goes with wiping out the imbalance of the good and bad bacteria, or just the ecosystem, our ecosystem in our bodies. Obviously, a contraindication would be if someone was severely allergic to penicillin. That would obviously be a contraindication. Strong caution to people with taking cephalosporins, because there is some overlap with, if you're allergic to penicillin, there's a higher risk you might be allergic to cephalosporins. The cephalosporins, cephalexin or Keflex, bacterial endocarditis, it can be, and actually I should change that. They don't really say bacterial endocarditis because so often it can be a bacteria, it can be a virus, it can be a bunch of things. I mean, if they cultured it, they could find out, yes, specifically it's bacteria, but in general, they call it infective endocarditis because it can be different things. So I should update that. But so this can be used as an alternative if they are specifically allergic to one of those. But there's also other ones that they use as alternatives. Soft tissue infection or UTIs, urinary tract infections. It can. Yeah. And then may increase effects of warfarin again. So we have this, adverse reactions, kind of allergic reactions, rash, GI issues, and yeast infections. Those are like your biggies. Allergies, GI issues, yeast infections. Those are, you're just going to see that over and over again. It's just from wiping out that balance. Contraindications would be obviously if someone's having a severe allergic reaction, or use caution with penicillin allergies, just because there might be a little bit of a here it is, cross hypersensitivity. 10% of people who are allergic to penicillin end up being allergic to so just for kind of what to do and how to approach allergies, a mild allergy is like a rash. Does it say okay to use a cousin?
In the family.
Is that what it means? Oh my gosh. I'm like, a relative? But so like, are they talking about probably like a similar medication? Like, is that like a cousin, like a medical, like a drug cousin? I'm going to change that too. How did I not notice that? I went through this whole thing. My word. Okay. Slide 20. Change, and then the other one was before that too. What was that? 18 or 19. Okay. But the take home there, a mild allergy is a rash, like hives, things like that. Obviously, if someone is having swelling and difficulty breathing, that's not mild anymore. So we always want to take any kind of a small allergy serious, like a rash or something like that, because sometimes it's just those first exposures, and then it can, the next time or the third time, it can get serious. It can get life-threatening. Severe reaction, anaphylaxis or angioedema, that swelling in the face. And then do not use a beta-lactam of any kind. If they have that kind of a reaction, then they can't use any kind of an antibiotic that's in that family of drugs. Maybe that's probably where the word cousin came from, is they're like, it's the family of drugs, but just doesn't make as much sense to me. Okay. So moving on, so protein synthesis inhibitors. This is another kind of, another grouping of antibiotics that work on a different component of the bacteria to fight off an infection. So there's macrolides, lincomycins, and tetracyclines, or lincomycins. And under the macrolides, you have erythromycin, azithromycin. Under the lincomycins, you have clindamycin, and under tetracyclines, you have tetracycline, doxycycline, and minocycline. And these are all like generations. Usually they're like, you know, the top ones are the first generation, and then it's the second and third generation. So for the macrolides, the mechanism of action is that the antibiotic binds to the 50S ribosomal subunit to inhibit protein synthesis. So the only two things, there's a 30S ribosomal subunit on one of the other antibiotics, and then there's this 50S. That's the only time those phrases and that part that you have to kind of know comes into play, but both of them affect protein synthesis. So both of them inhibit protein synthesis, and it ends up with a bacteriostatic result. So this mechanism of action of macrolides is a bacteriostatic result. Common uses: upper respiratory tract infections, pneumonia, sinusitis. It can be used for acne or an uncomplicated skin infection. It has been used for STDs like chlamydia, and then bacterial infections like tuberculosis. For that purpose as well. So under the macrolides, you have the erythromycin and the azithromycin. There's lots of drug interactions. They're more severe with erythromycin, so that's that first generation. And then the second generation, azithromycin, there's not as many drug interactions. Warfarin, again, we have here anti-arrhythmic drugs. There can be some reaction. Digoxin, which is a congestive heart failure drug. Cholesterol meds, antidepressants, etc. So there's a lot of caution. So doctors who prescribe erythromycin or azithromycin are very cognizant of that, and they would probably choose something different if they could. So adverse drug reactions, GI issues, more with erythromycin than with azithromycin, rash, cardiac arrhythmias, contraindications, obviously allergies to a macrolide, use with different drugs, and caution with patients with myasthenia gravis. And we'll learn a little bit about that. That's an autoimmune condition where it causes a lot of, it's something that has to do with the myelin sheath on the neurons and the nerves. And it ends up causing a lot of weakness in their speech, weakness in their muscles around their head and neck. But anyway, so we'll talk more about that in special needs, but that's another contraindication. So the lincomycin drugs, clindamycin or cleocin, common use for this: bacterial endocarditis or infective endocarditis prophylaxis. It can be an alternative to patients who are allergic to penicillin, skin infections, bone infection, anaerobic infections, and again, bacteriostatic. So that's its mechanism of. Very few drug interactions, so that's nice. It can have GI issues, Clostridium difficile, diarrhea. That's a big one. That's where their GI is really affected and the good bacteria is really wiped out. Yeah. On the key. Oh, it's on the actual. Oh yeah, it does say microlides. Yep. You're like, where's the microlides? I see the macro. Okay, thank you. Yeah, I'll change that. But yeah, if everyone crosses that out and just puts macrolides. Yeah, back of the second page. Thank you, Nikki. It's later in the presentation. It's coming up. Yeah. Mm-hmm. It flashes at you. Okay, and not sure why yeast infection is in red because it can happen with a lot, but maybe it's very common with this drug more than others. Contraindications, allergy, pseudomembranous colitis, ulcerative colitis, overgrowth of the dangerous bacteria. So that's just again that that wiping out of your good bacteria, the balance is out of whack, and the Clostridium difficile can take over and cause a lot of watery, super watery stool, and it can cause a lot of problems for people to get back into a healthy GI gut balance if it wipes out the good stuff. Tetracycline, so we have the macrolides, the lincomycins and the tetracyclines. So mechanism of action for the tetracyclines is the drug binds to the 30S subunit of the ribosome, and it inhibits protein synthesis. So the same as the macrolides, it's just 30S ribosomal subunit instead of 50S ribosomal subunit, but it does the exact same thing, prohibits protein synthesis. Common uses, skin infections, acne, MRSA, respiratory infections, pneumonia, bronchitis, Lyme disease, STDs like chlamydia. And so this is asking, is it cytal or static? Yes. Okay, tetracyclines, drug interactions. Tetracycline can get bound up with some of these minerals, and so it's not going to work as effectively. So calcium, magnesium, aluminum, and iron. And then with warfarin, it messes with the enzyme of the metabolism, and it can end up with warfarin being in a higher concentration in the blood. So those with tetracycline, those are some of the drug interactions. GI upset, photosensitivity. So this is important to know. Patients who are on tetracycline medication could burn more easily. They'll be more susceptible to sunlight, so they can get a burn. So you have to kind of be careful of that when they're taking one of these drugs. Rash, yeast infection, allergy contraindications, same as a lot of the other ones, but a little different and super important to note. Allergy to tetracycline, but pregnancy, so it can be detrimental to the fetus, but also to young kids or anybody that's developing tooth enamel. So everybody in dentistry knows this. Doctors, physicians should know this really well too. If you ever come across somebody that's trying to prescribe, if you have the ability to intercede, be like, no, don't do it. They used to do this all the time. They used to prescribe tetracycline to young kids. And if the enamel is in formation, if they're young enough and things are still forming, even, under the gum, like the tooth buds, like they're still in formation. If tetracycline is introduced, they'll get this stain, and it does not go away. You can't bleach it out. You can't brush it out. It is part of the tooth. And it can be bad. And you don't see it so much. I saw quite a few in my early years because that generation had been exposed more. So I probably saw at least 20 people who were, above the age of, probably at least at that time, above the age of 50 or something. But sometimes people who come from another country and maybe they don't know that, or they don't have access to anything else, and that's the only antibiotic. So you might see it also still maybe from somebody who's come from another country too. But in general, you don't see it as much nowadays. But it never gets prescribed to anyone under the age of 8. Okay, and some other really interesting things about this family of antibiotics is that the tetracycline antibiotics have an affinity for the kind of the cervicular fluid and this area, and they tend to hang out in this area, which is very advantageous for us because we have all these viruses and bacteria and funguses in the sulcus that's causing periodontal disease. And so, you know, it's great that we have a drug that actually wants to hang out and come into this area. So they have there's some different medications that have been discovered or developed to work in this. And you'll learn more about Arrestin specifically over the summer. We'll place Arrestin in a typodont, and then you'll have an opportunity to place Arrestin on clinic patients. But another one that's super interesting is Periostat. That's a pill. It's doxycycline, so it's in the family of the tetracycline drugs, but it's low dose. So it's 20 milligrams or something, and it's not acting like an antibiotic. So that's not the purpose of the drug, is to be an antibiotic. It actually affects what breaks down collagen in the area, in and around the periodontium. It works on that mechanism that's breaking down the collagen, which we don't want, and it helps it not break down. So it has like this totally other mechanism for whatever neat reason. And so they prescribe it in this super low dose, and it's not in enough of a concentration to be an antibiotic. So it's not classified as an antibiotic.
Is it like an
It specifically works on the collagenase, or what breaks down collagen. So it probably has some kind of an anti-inflammatory mechanism. I don't want to talk too much about it because I really don't understand it fully, but I know that it works on that mechanism that's breaking down the collagen in the periodontium. So it's pretty cool. They have found, like, there's lots of studies on it. You can do research on the studies of Periostat and low dose doxycycline. And then there's other drugs, like there's Atrodox, which is also doxycycline in sort of a gel, and you put it down in the pocket and it's kind of liquidy, but once it comes in contact with that environment, that periodontal pocket or sulcular environment, it sort of firms up and becomes like sort of waxy. And then it stays in there for like, I don't know, 2 weeks or something, and it just slowly dissolves and gives that environment a chance to sort of, fight a little bit the infection. Arrestin does a similar thing, although it's minocycline, and it's little beads. When you put it in, it's like a yellow powder. It looks like pollen, and then you put it down into the pocket, and then it sort of gels, and then it slowly dissolves. So there's special instructions you give your patient: don't toothpick, don't pick at it, don't floss the area for like 2 weeks. Yeah. You guys will be using Arrestin in clinic, yeah. So, and you'll get more about this in another class, but it's really expensive in the world. It's like $75 per, this little picture here, that's for one site. So say someone has a 6, 7, 8 millimeter pocket, you'll put this, where'd my mouse go? You'll put this amount up into that pocket, and that'll be like $50 to $75. Well, someone could have like 7 areas like that. So 7 times 75, and insurance doesn't cover it. I mean, it's pretty silly. But there are things that show that it works, and some dentists are very much like, they push you to educate your patient as best and to do it, to give it to your patient. You guys have the opportunity to give it to your patients here for free. So take advantage of learning about it and how to use it, but just keep that in the back of your mind that it's expensive and it's not covered by insurance typically. And so you have to bring that into your whole kind of care understanding. Okay, moving on to the quinolones. What time do we got? We're almost there. Okay, so here's a video that I would love to play, but I don't want to take the time. So please watch it. But I'd say I don't want to scare you, but it's specifically about ciprofloxacin and this family of drugs, and it's a side effect, a rare side effect. Did anyone watch it yet? Not one person. Okay. Actually, I think I just posted this last night, right? Okay, yeah. You want me to play it? You guys want to play it? Okay, it's a news thing. I think it's 5 minutes. It won't let me play it. I'm sure I could. You guys are like, just play it. It's a kind of sad though. Aren't you delicate snowflakes? You're already sad. Like we're already all sad and depressed. Why won't it? Do you think so? Has it been censored, you guys? Oh my God. Hold on. I know how I can find it because I emailed it to myself. It is. It's about suicide. Did you find it?
Rise in one of the most widely prescribed antibiotics on the market. IT investigator Jackie Calloway first exposed the dangers of Cipro and Levaquin back in 2015. And new tonight, she reports on the fight to raise awareness of one less known risk of taking these drugs: suicide.
Happy birthday to you. She was larger than life. 49 is last year.
Do you see it?
Not Don Mendoza's husband of 21 years, or the two daughters she loved fiercely, imagined those words would prove true. In a million years, did you ever see your wife taking her own life?
She's fine for 27 years. No attempt of anything, no depression.
7 months after her birthday, Mike Mendoza came home for lunch and found his wife at the bottom of their pool.
It's really
She
depressing.
had lashed herself to a chaise lounge and rolled herself into the pool.
Mike blames the powerful and commonly prescribed antibiotic Cipro for Dawn's death.
Like Tuesday, bad anxiety at night.
Dawn journaled her downward spiral in the days after a doctor prescribed Cipro for pneumonia.
Since Thursday, September 12th, I have slept only on Monday. Insomnia, anxiety, racing heart since Thursday, September 12th.
And texts on her phone indicate Dawn notified her doctor's office about the anxiety and insomnia. Did anyone say this might be the Cipro?
No, never.
In the search for answers, Dawn read the Cipro drug insert and found anxiety, insomnia, and suicide warnings on page 12 of a 52-page insert.
It says, feel like I'm dying inside out.
The woman who cherished her girls and loved life ended her suffering 4 days after taking her final dose.
911, what's your emergency?
She parked her car on the side of the interstate
This is a different story.
and walked in front of a semi.
It's so depressing. I'm so sorry, you guys.
Deanna Pokin's family also blames Cipro for her suicide.
It was not her. She would have never, ever, ever done something like that.
Reports filed with the FDA tied 219 suicides to Cipro and Levaquin, two popular antibiotics used to treat serious infection. The FDA says only between 1 and 10% of all adverse side effects are ever reported.
And the FDA should revise the package label.
Dr. Charles Bennett, a nationally recognized medication safety expert, petitioned the FDA in 2014
For quinolone-associated toxicity.
and again in 2019 for increased suicide warnings for Cipro and Levaquin.
a class of drugs called fluoroquinolones. In 2018, the FDA issued its strongest black box warnings for these drugs. It states the antibiotics are associated with disabling and potentially permanent side effects of the tendons, muscles, joints, nerves, and central nervous system. But the agency denied Dr. Bennett's petition to add suicide as part of the boxed warning, leaving it as a subsection on page 12 of the package insert.
And physicians and providers do not still have any idea about the side effect.
In an attempt to raise worldwide awareness, Dr. Bennett started work on another petition. It will ask the CDC to recognize fluoroquinolone long-term toxicity as a condition that can be billed to insurance.
Biggest way that people say to get the providers to pay attention is when they can bill for an incident.
But the process could take years. Meanwhile, the makers of Levaquin stopped making the drug, citing other options for treatment. And this week, Cipro's maker Bayer responded to us in a statement. Fluoroquinolone antibiotics treat a wide range of bacterial infections. The Cipro label already contains FDA-approved language advising physicians and their patients about the potential side effects, including specific warnings about the risk of central nervous system and other psychiatric effects.
So I think that's the main gist. So obviously, thank you, Jenny. So obviously medications have very rare side effects. And that doesn't, so that's why I was like, oh, it's scary. But I just think it's so interesting because I think sometimes we get so complacent with medications. And I just think it's really important to like, think about what you're taking and ask your questions and then just be able to be informed about what it is. And I just came upon that like so randomly. And it was at the same time that I was prepping for this. And I was like, okay, should I share this? Should I not share it? Because I do think there's a little bit of like a dramatic, fearful piece to it. And lots of people probably take Cipro and are fine. But I just think that it's just important as healthcare providers to know that everything and anything has risk. And the most important thing is that when you have risk, you're informed. I just think that's the most important thing. So let's go from that incredibly kind of depressing piece to just finishing out a few more slides here. And then we're going to take a break. What do you guys think about that, though? Does anybody have any comments on that at all? From an antibiotic? I think that's the thing is I think every drug that's out there, if you read down far enough in the side effects, you see like freaky stuff. And so it's like risk benefit. Well, you just have to do that. And so I think my mom had got a prescription for that from her doctor and that sort of like triggered it. So the whole thing kind of came to at the same time. I was like, I don't know if you should be taking Cipro. Can she give you another antibiotic? I was like, I don't know, but I'm probably just a worrywart. But yeah.
Well, it's kind of stuff that like the providers don't care unless it's like available.
I think that's part of the conversation that I think is really relevant is that what are our motivations? Like, is it money? You know, just like you said, if it's not billable, then they probably might not care as much. But you can't like squash something that is like potentially, life ending. So it's probably worth a bigger discussion, probably in a different health course, I guess. I should find that course and try and teach it because I like those topics. But anyways, okay, so we're gonna move on to I don't know if so most commonly for Ciproflox, for Cipro, it said the most common prescription are people with chronic bronchitis, but then there are these other upper respiratory conditions, chronic periodontitis. Someone may be prescribed Cipro for chronic periodontitis. I haven't come across a ton of Cipro in my clinical career, but I definitely saw it for sure. And then they are Cyto. They are not technically antibiotics. They're 100% synthetic. So this group of drugs, this fluoroquinolones, they're totally synthetic. So they're created differently, but they interfere with the DNA of the bacteria, and they are Cyto. There is photosensitivity as well with these drugs. So if someone's on ciprofloxacin, they're going to be more susceptible to burns, dizziness, headache, cartilage damage. There's an interaction between warfarin again and caffeine. It can increase those. So it can increase the amount of warfarin in the blood or caffeine. You might get more jittery if you take it when you're taking coffee, drinking coffee. And then things that will bind it. So dairy products, iron, antacids, they're going to kind of bind it. So they'll inhibit absorption of the drugs. And then metronidazole, or Flagyl, this one is the one that you want to flag for the alcohol use. So this is also a Cyto. It interferes with the DNA. These are some chronic uses. H. pylori, that should kind of hit your memory from when we were talking about peptic ulcer disease. So Flagyl could be prescribed for that. Protozoal infections, periimplantitis, or infection around an implant, necrotizing gingivitis. It's like where it's like necrosis, really bad sores and just necrotic gingival tissue. So all those reasons, metronidazole can be prescribed. And so because it interferes, yeah, it's flashing, there you go. So because it interferes or has a reaction to alcohol, we have to be careful that if our patients are taking this antibiotic, that we tell them not to rinse with alcohol-based mouthwashes, not to ingest any alcohol. Yeah. Mm-hmm. Crazy. Yes. Like a toner or something that has alcohol, or hand sanitizer. Crazy. And it says up to like 3 days after you stop medication. So it really is a strong drug interaction, and that can make people sick, just feeling sick and yucky. Again, warfarin is there again if they're pregnant, first trimester especially. That's so funny. I remember this from last year. I have no idea. My brain is drawing a blank with ETOH. Does anybody have a guess? Huh. Oh, that's probably what it is. Is that what it is? Okay. I knew somebody was going to be able to work that puzzle. I remember seeing that last year and being like, what the heck? But that would be ethyl alcohol. It's maybe the chemical, some kind of chemical abbreviation. I'm going to fix that because I hate coming across things like that and then being like, what is that even talking about? Slide 33. Okay. So I'm going to pause here because we kind of shift gears. So those are all the antibiotics that you got to, but do you see how it's a lot of medications, but there's a lot of repetition, lots of GI. There's a few things that you're going to want to pull out: photosensitivity, the alcohol reaction, knowing warfarin is a drug. So there's a lot of repetitive, but then a few things you're going to want to pull out. So those are the things to really pay attention to. So let's take a break. So it's 9:38. Let's come back at 9:45. And then we'll finish up this part talking about prophylaxis, and then a little bit of antifungals, and then prescription writing. So we should be able to finish up. So 9:45. Ethanol. Ethyl. I gotta pause my recording here. Hold on just a second. Hopefully I'll remember this.
Everyday thing that we need. not making money off of it.
Yeah.
But some people are getting really bad MRSA.
I had MRSA. I know, I had MRSA, and I was trying to remember, I had it on my, I was working in a nursing home, and I got it, I know, and I got MRSA on my wrist, and it was, I have a scar, because I had to go and they had to lance it. It was bad for like a month. I had it for like a month. And I can't remember the antibiotic that they gave me. It was not vancomycin, because they told me, they said, if this doesn't clear it up, they gave me one antibiotic that did literally nothing, like nothing. And then they cultured it, and they found out exactly what it was. And then they gave me a second antibiotic, and that cleared it up. And they said, if it doesn't clear up, then there's vancomycin that they give you.
My brother had it on his arm right here, and he almost had to get his arm cut off. He was having heart problems.
Yes, I wanted to write an article on MRSA and healthcare and dental hygiene. I still might, because it's not super common, but when you get it, it is like, whoa. I mean, it like changes your thoughts about bacteria.
Yeah, like now I'm like people are paranoid about. That's like my biggest like.
Yeah, it's crazy.
Like that's why I'm like, I don't really want to go to the hospital. I don't really want to go.
Well, though, that's where a lot of times it is at, for sure. Okay, I don't have a bell. Okay, you guys, we're gonna get started again. I'm getting us going a little bit late because I'm horrible at paying attention to the clock. Okay, so we have just under we have about 25 minutes left, and I think that's plenty of time to get through this material, but do want to make sure that we do. So endocarditis. So one thing as a dental hygienist, you will experience talking to your patients about taking pre-medication. It's becoming more and more hello, Janice. It's becoming more and more like less common, really. They're sort of taking away things that that you need to pre-med your patient for, or give a prophylaxis, a preventative course of an antibiotic to prevent something, because they're doing studies and they're like, this doesn't really seem to cause very much benefit for the patient, and we're just giving antibiotics for no reason, which of course they're concerned about the resistance. So when I was telling Ebeth that when I was in school, anybody who had a mitral valve prolapse, like a heart murmur, got pre-medicated. Like just everyone did. If you had mitral valve prolapse, you got pre-medicated. Well, that's fairly common. It's not that uncommon. And so that ended pretty quickly. And then they've just kind of they've kind of gotten more specific. And then the joint, the artificial joint replacement, hip and knee, and I guess you could have other joints, but hip and knee are the big ones. That's kind of this weird controversial place where in dentistry, we're like, we don't think it's necessary, but the surgeons who do the surgery, they sort of have a little bit more of they just want to cover their bottoms, because if they don't tell the patient to take a pre-med and then something happens and bacteria congregates around the joint and the joint fails, and they feel like that could have been prevented by them taking an antibiotic, they're just doing kind of that CYA, cover their butts. And so there's just a little bit of controversy there, but in general, that has sort of been like, it's really not necessary. If they're healthy, if they're not severely immunocompromised, if they've had a failed joint in the past, there's all these different aspects where so what I always said as a clinician is, put it in the court of the surgeon who did it. Do you want your patient to have a pre-med? Fine, tell your patient they need to have a pre-med, and that's fine. But as on the dentistry part of it, we've probably pretty much said that that's not necessary. When it comes to heart stuff, pretty much anything that revolves around valvular issues, like artificial valves, artificial parts in there to help a valve function, shunts, congenital defects from birth that have had things, anything kind of like artificial, anything that interrupts the flow of blood, and then can then have an area for bacteria to congregate. So pretty much anything that has to do with the valves can be a red flag. But first, let's talk about the regimen. So one of the questions on your study guide says, where is it? What is the standard regimen for infective endocarditis? So this is some standard regimens. Amoxicillin is the most common. So what you want to know is that when your patient comes in, if they're not allergic to penicillin, then you'll say, you note that they need a pre-medication because of the condition that was red flagged and it's been highlighted, this patient needs a pre-med. And you'll say, did you take your pre-med? And they'll say, yes, I did. Well, what time did you take it? And what you're noting is that they took it at least an hour before the procedure. So if they had a 9 o'clock appointment, they hopefully took it at 8. And 2 grams is the standard 2 grams, but that's given in 4, it's broken up into 4 pills. So it's 4 pills of 500 milligrams a piece. So they'll have taken 4 big old horse pills of amoxicillin, 1 hour. PO is by mouth, so 1 hour orally before their procedure. That's a standard regimen. So you'll say, did you take your pre-med? Yes, I did. I took it at 8. Make a note in your chart. Okay, great. They don't have to take any more antibiotic. They're good. They don't have to take a follow-up or anything like that. That's just the standard regimen. If they're allergic to penicillin, likely they'll take clindamycin. Those are the only 2 doctors that I've worked with have ever prescribed, but I'm sure there can be other ones. So cephalexin, although there is a cross with the Keflex, there can be a cross allergy. So I don't know that they'd give this one if they're allergic to amoxicillin or penicillin, and then azithromycin. So I know this one by heart and this one by heart. I wasn't as familiar with these 2 because I just didn't have as much experience with those. But this is 600 milligrams by mouth, 1 hour. And note, it's always by mouth. It's a pill, usually a tablet that they take 1 hour before the procedure. Okay. Am I still sharing? Yeah, I am. Oh, the stars are the answers. So here, I pulled this last year, and I will say I did not update. I did not look again this year, and I feel like I probably should have. So I'll probably look at that, and if something needs to be updated, I will change it. But we talk about pre-med in other classes. So if something's not jiving with something that you get in another class, then that's fine too, because a lot of things you'll get you can get them in different classes because they're so important and they relate to different aspects of dental hygiene care in different ways. So you'll hear more about pre-med anyways. But I highlighted, so this was the current last year. So I'm assuming it's still current because it usually doesn't change that often. But this was what was on the American Dental Association website for antibiotic use. So prosthetic cardiac valves. I highlighted everything and you can see it's like valve. Prosthetic cardiac valves, cardiac valve repair with some kind of material that they used. History of infective carditis. So if they've had IE before, that just automatically puts them at risk, even if they don't necessarily have a valvular issue. If they're like, I had IE before and I was in the hospital, then they get a pre-med. They just get to join the party just because of that. A cardiac transplant with valve regurgitation, structural abnormality of the valve. So again, focusing on the valve, following congenital heart disease present at birth. So unrepaired cyanotic congenital heart disease, including, so here's the shunt. I should have highlighted shunt and conduits because that should be highlighted more. And then any repaired congenital heart defect with residual shunts or valvular regurgitation. So I should have highlighted shunts as well. So you can see, or prosthetic device, prosthetic patch. just think about anything that someone's had done to their heart that could be impeding the flow of blood. Yeah. Oh. Uh-huh. Yeah, the clearance. Yeah. Everything's ready, and then for whatever reason they can't. And you'll also have patients come to you. This is from the American Heart Association, antibiotics before dental treatment. So this is a little bit less detailed. Patients with artificial heart valves, history of infective endocarditis, patient having serious heart conditions present from birth, congenital. So that's says similar, but way less detailed. I kind of like the other one just so it gives you kind of a more comprehensive understanding of what is actually flagged as necessary. This is a decision tree that I found last year. I thought this was really helpful. Oh my word, sorry. Cough, cough. When it's appropriate to prescribe prophylactic antibiotic for patients with an orthopedic implant. So implant patient has planned dental work, yes. Okay, is it an invasive dental procedure, yes or no? Invasive means is it going to cause bleeding? Like, are you going to do something to the patient and it's going to cause bleeding? Exploring, probing, invasive, those are invasive. So yes or no, so let's say yes. Severely immunocompromised, yes and no can sort of still lead to the same place. So let's say no, they're not. Do they have a history of a joint, history of PJI, so an infection requiring operation? Yes, maybe then you do want to give them a pre-med. No, it's probably not necessarily. So it just gives you like a decision tree on how to get to the answer, which is very oftentimes the answer is no. But again, if it's a joint, it's kind of like, what does the doctor, what does the surgeon want to do? Because it's sort of more in their court. Here's just a table that you can use to kind of help you with all of these things. I would highlight things that are similar, like write them all out and then maybe use different colored ink or something, or I don't know, to kind of help you see the repetitive nature of some of these. But this is just an idea of the different things you want to know. And then this is just another, I thought this figure was really neat because it shows a bacteria and then it shows the antibiotics that work on the different parts. So this is just a nice visual because you have tetracyclines, they work on the 30S ribosomal subunit. And then we have the erythromycins, they work on the 50S ribosomal subunit. And then we have these that we didn't even talk about. So this isn't necessarily anything specifically you need for a quiz or exam, but it might be helpful in helping clear up some of the stuff that would be on a quiz. So, obviously if, rifampin, we didn't talk about that. We didn't talk about vancomycin. So you don't have to know that for a quiz or exam, but it's kind of cool to see the different medications and what part of the bacteria they work on. So I kind of like that. Okay, conclusion, many different classes of antibiotics, different target sites, different bugs are killed. It's either inhibiting it or it's either static or cytal. And we want to use them wisely so that we have them around for later use. So now we're going to talk quickly about antifungals. So fungal infections are caused by molds and yeasts and whatnot, and people can get them for a couple different reasons. If your immune system is compromised, if something, maybe you're just more, some people could be maybe more prone to certain types of yeast infections or candidiasis, but usually has obviously more susceptibility if your immune system is compromised for sure. Antibiotics will do the same thing. It might knock out the balance of the flora and make you more susceptible as well. So for the antifungals, we're just focusing on three different groups, I think. The first one is the azoles. We have the miconazole or the monostat, and then the clotrimazole, the Miselex, and then we have the polynese. and the Nystatin drugs. So Nystatin is something you might see for in the dental office for thrush or oral candidiasis. Some differences here. The azoles are the static. They're the ones that are just sort of weakening their reproduction. Specifically, they block the ergosterol synthesis. And then Nystatin is more of the cytal. It's actually killing the older yeast. So for the azoles, the miconazole and the clotrimazole, the common uses are either an oral or a vaginal candidiasis or a fungal skin infection. There is, again, some interaction here with warfarin. We can see that. And then cyclosporin, which is an immunosuppressant. So there's some drug interactions there. Adverse drug reaction. There's minimal systemic absorption. So a lot, these are topically applied, unless they're systemic antifungals as well. But these specifically are topically, but they don't absorb heavily into the system. So it's more of like local irritation as opposed to systemic reactions. And of course, contraindicated if someone has an allergy. There is a product that's the miconazole. There's an oral, like a lozenge that if someone is fighting thrush that keeps coming back, that's usually going to be seen most commonly in like an elderly person who is wearing dentures or in the nursing home. They're going to be immunocompromised. Maybe their flora is super out of whack because they're just not, their dentures not being cleaned. They're not having the good oral hygiene, and then their body, their system is immunosuppressed. So you can see it in the elderly quite often, especially if they wear dentures. And then also like somebody who has an immunocompromised condition, like if there's AIDS or cancer treatment or something like that, then those are the conditions that you would see more of oral candidiasis. So they have this medication that's like a lozenge that actually they stick it to the mucosa and then it dissolves slowly, and it just releases this antifungal medication slowly over the course of 2 weeks. Again, another way that if patients come in with some kind of oral candidiasis, it's not even the thrush, like if they don't have like heavy white plaque buildup, but it's just like red and raw, or if they have the angular cheilitis that's just not going away, they might be prescribed Nystatin in like either an ointment or an oral suspension, like a rinse. So there's a couple different ways that you might come in contact with that in your private practice. The dentist will prescribe it, but you might recommend it to the dentist. Say, hey, maybe we should think about prescribing Nystatin for this patient. They've been struggling with this angular cheilitis or this, this oral candidiasis that I think they're experiencing. You talk about it with the dentist. So for the Nystatin, oral or cutaneous fungal infections, there's not a lot of drug interactions. They could have some GI issues or some local irritation. Contraindicated if they say I'm allergic to Nystatin and you don't give it to them. And then for a systemic antifungal, fluconazole or diflucan, this can be used for like vaginal candidiasis or severe oral esophageal candidiasis, like something that's like really taking over sort of systemically, and it's really like a strong yeast infection or some thrush or something that they need something stronger. Like there's warfarin again. This has a drug interaction with calcium channel blockers. Diflucan can elevate liver enzymes. So, some of these are like 1 pill or 2 pills, but if they have to be on it like for a longer course, they have to check their liver to make sure that their enzyme levels are good. Can cause nausea, vomiting, diarrhea. And it didn't specify in the book specifically of contraindications, but I'm assuming obviously if they have liver, some kind of liver dysfunction, that's going to contraindicate, or, they're not going to be as much of a good candidate, or if they are allergic to the medication, obviously they will. Here's another little table for you to use. This is not as much information, but knowing that how these medications, especially Nystatin, is the biggest one that you'll see probably in practice, and then the miconazole. Those can be used in. Okay, so I'm going to switch gears. Got just a few more minutes. We're going to do the prescription writing. That'll probably take us 5 minutes, and then we will be done. I'm going to stop sharing for just a second. And open up the other one. Okay, so prescription writing, there is a lot of slides here, but I'm going to just fly through it. There's 23 slides. So with prescription writing, hold on, sorry. Here's my one. Okay, so here are the objectives for prescription writing. Understanding basically your role in prescription writing. If you're not an EPDH that has a contract with a dentist, you don't have a lot of prescription writing like abilities other than fluoride and maybe chlorhexidine. But it's still important to know that, because the dentist might have you do all the prescription writing, and it's probably on your computer like a tablet that you just fill in the patient's name, and it might be pretty standardized, but it's still important to kind of know the basics. Identify the various parts of a written prescription, develop clinical skills for prescription writing. It's super easy to completely forget this. And then all of a sudden, one random day, you're supposed to write a prescription and you're like, how do I do that? And so it's just really good to be kind of abreast of this, all the different components here. Discuss how to avoid errors in prescription writing, discuss issues related to prescription writing and with controlled substances. FYI, you don't write for controlled substances, so I'm not going to spend very much time. So a dental hygienist under the supervision of a dentist may prescribe, so this is right out of your Practice Act. So here it is, this is what you can do. A dental hygienist can prescribe, administer, and dispense fluoride, fluoride varnish, antimicrobial solutions for mouth rinsing, or other non-systemic antimicrobial agents. So non-systemic, so maybe like specifically an ointment or a rinse or something. An expanded practice dental hygienist, which you all will be when you leave here. However, none of you, when you leave here, will have a contract with a dentist. Highly unlikely. If you do, come and tell me about it. I want to know. But you might look for that. You might go out, practice a year or two, find a dentist that you can, there's a different name for it, not contract, but the word is escaping me. So it's like, but it is a contract that the dentist says, I vouch for this hygienist, and these are the things that she can do when I'm not around in her own practice, your own private practice. So an expanded practice dental hygienist with an agreement with a dentist can prescribe prophylactic antibiotics. So you can prescribe amoxicillin, clindamycin, NSAIDs. You can prescribe a prescription strength ibuprofen, or etodolac is a type of an NSAID that I used to give my SRP patients, etodolac, before I did SRP. It's just to onboard a pain med. It's not a narcotic, so you can prescribe that if you had this type of an agreement. All applications of fluoride, local anesthetic. So there's parts of a prescription. This is an old-fashioned pad. Now, a lot of times it's just on the computer, but you have the heading, you have information here, your DEA number, which none of us have. You won't have a DEA number. Your patient's name and address and age, the date of the prescription. Then there's the body here, which is the medication, how many you're dispensing. SIG is sort of your written out instructions. This is like take 2 grams by mouth 1 hour before procedure. That's your SIG. And then you have whether it's if there's any refills, and then you're going to dispense as written or give permission for generic. So an alternative. This breaks that down again. So that's just what I basically said, but you can read that over. It breaks down the pieces a little bit more closely. These are the schedules of drugs. DEA, we don't have a DEA number. We can't prescribe controlled substances. So this is good to know, but that's all you really need to know, is that we don't have one. We can't do that. We do, however, can get an NPI number, which basically sort of, it like establishes us in the government. It gives us sort of like, this is my healthcare provider number. So it kind of establishes us in the big system of everyone will have a unique NPI number. And you will need to get an NPI number if you want to do EPDH work in your own practice, or bill Medicaid or Medicare, bill insurance. You will have to have an NPI number. If you are an entrepreneurial spirit, you want to open your own practice, you will need to get one. And this is how you do it. It's very easy. You go to this website. What? You go to this website. Oh my gosh, there's 3 minutes left in this class. Okay, I'm skipping. This is what you need to know. Go back and look at that. It's super easy to get your NPI number. Go back and look at it. This is what you guys need to know. You need to know common Latin abbreviations. You need to know things like BID, QID, PO by mouth. You need to know these abbreviations. You will be tested on these abbreviations, especially the ones that show up in your study guide. Those are the most common ones. You will be tested on those. There's 10 more slides. What's here? Let's just fly through it really quick. These are examples of how to write prescriptions. Note the medication, the dispensing, and then the SIG is the instructions. Take home point. When you're writing a prescription for ClinPro in the clinic, don't just write like ClinPro. Write like, give your patient a brief instruction. Take a pea-size amount, figure out a nice 2-sentence, maybe 1 sentence really, instruction. Pea-size amount, brush with pea-size amount prior to bed or whatever. No eating or drinking for 30 minutes. You think about the things that you'll learn if you or have learned in your community oral health class with prescribing fluoride, or what you tell your patients. They don't eat or drink for half an hour. Whatever it might be, the best time of day to do it. Those are the kinds of things that you put in the SIG. So you don't just say like, here's your ClinPro, good luck with that. You have to give them like an instruction on how to use it. So it's just like with a pill, if someone's like, take this in the morning or take it every 12 hours, or, you have to give them some kind of an instruction. So that's the take home point. And I think that's probably the summary of this entire thing. There's good information here about the fluoride dosing. So if you are to prescribe fluoride, you have to know proper dosing. So take a good hard look at that. And then the rest of it is just examples. These are all just examples. And then practice. Here's a case and another case. So look at that and use those, but because probably the most important thing is what I said about writing a prescription, and then also these highlighted numbers of fluoride. That's important too, because if you're going to write for a prescription for fluoride, you better know what the dosing is, right? You just don't want to go happy. Okay, yay! 10:20 on the dot. That's it. You guys, I'll send you an email when I get the quiz on Moodle.